now?
Yes, yes, we
Yes, yes.
agree.
Yeah, thank you. At the outset, I would like to thank Dr. Deepak, Professor Shrikant, Professor Milind for giving me this opportunity and all the respected dignitaries of UPSOS and Bihar State Ophthalmic Society. My topic for today's presentation is challenging Rhexis scenarios. So I would be having more of a video presentation, and I have no financial interest. But yes, I would like to acknowledge my alma mater, SNC Chitrkut, where I was working for almost 11 years. So challenges that we face are either due to patient factors, like sometimes you get a patient who gets head nodding, and sometimes he has ankylosing spondylitis, he's not able to lay down properly. Sometimes we have associated diseases like uveitis where the pupillary dilatation is poor, and surgical challenges are because we maybe as a beginner or even as an expertise also we do face certain situations during surgery which we have to manage. So this is a 7 odd minute video which I'll be presenting on challenging Rhexis situations uh, that I've faced in my this surgical life. So these are few of such situations. So first of this patient which I am sharing here is a patient who had a severe head nodding. So this was an aged female and she was unfit for GA. So one situation where what you have to do is you have to actually calm this patient. You have to calm yourself, and you can see that I am putting iris repositor inside, which is trying to stabilize the eye, and then you have to counter the thrust which is there. So external factors like head nodding you have to manage. So take home messages, instrument stabilizes the eye and make your patient calm, because you realize over a period of time the head nodding decreases, but with time it increases again. So you have to manage with that. I mean, you can use iris repositor to stabilize your eye. So this is again a second cataract where you can see there is a posterior synechiae. This was a young male who came to us from Lucknow. So after putting iris hooks in place, ideal the key here is that you should have an adequate exposure. These patients, they are mostly young. The cataract is soft. All you have to do is put a iris hooks properly. You have to take care not to injure the capsule, because you might cause a tear in the capsule, and see how well the Rhexis was done in this case, and IOL was implanted. Now again with uveitic patients, you can get complicated cataract like occlusive pupillary. And here I am using a cystitone to rupture that in membrane. But here after rupturing, I noticed that I did created a tear in the entire capsule, and I had to stain that capsule in presence of visco. So you can see that flap and trying to catch that flap of Rhexis. And this Rhexis, initially it went outside, but now I would be catching this Rhexis and trying to pull it in, and I was quite successful. And now the Rhexis part was done. This was again a young patient. You can see a white cataract, but these cataracts are mostly soft. So once you have gained a good exposure, once you have got a good Rhexis, then doing phaco in such patients isn't a big deal. And ideally, uveitic patients, you should do phaco because you should put the IOL within the bag. So see, I'm polishing the capsule here, and you can see the Rhexis. So this is one case where you can see it's an intermittent cataract, and I usually do spiral Rhexis. And in between, with the help of visco cannula, I try to debulk also where possible. But here during debulking, I was not careful, and I did created a nick. Just watch here again, and now see there will be a nick. See, this is a nick created. Now this nick carries a risk to extend to the periphery. Now what I have to do, I have to put in good amount of visco. I have to flatten the anterior chamber as far as possible. Now the only option left is to catch this flap and do a reverse Rhexis. And see, I am catching this flap and I am trying to do a reverse Rhexis. Now my intention is to complete this Rhexis after taking that initial flap also in the loop, so that my Rhexis gets completed. And see, after putting in visco, I am doing that Rhexis and I would be successful in taking that initial flap. The Rhexis was done, however, it was a bit eccentric. Now this is a calcified capsule. You can see I am having difficulty even in raising the first flap. So I tried a lot to catch this capsule, to rub this capsule with Utrata's forceps. Finally, I had to go in with Vana scissors and I have to cut this capsule. But this was not just one cut. I had to make 3 side ports in this patient to cut this capsule to achieve a good Rhexis. Even I faced some criticism also when I posted this on YouTube. People said, why are you making so many side ports? But because you have to do phaco, even with SICS also, to gain that Rhexis, you have to cut it with Banas. Otherwise, if you would just go and pull this, it will cause granular dialysis. And see here again, I met a fibrous point and the Rhexis was not able to go beyond this point. So I had to create another side port, and with Vanas, I did cut this flap again. And then there will be another third point where I have to cut because this was quite thick. Now you can see when I will be just rotating this flap, you can see how thick this fibrous flap is. Now see here how thick this fibrous flap is. And this is a strong area of fibrous adhesion, which I met during my surgery at 3 places. And this is one place. Again, this is the second place, which I'm showing again in high magnification. And now you will be seeing after moving to this side, again, if you notice that there is a thick fibrous area, which is not ready to give way. So I had to make another side port and do one more cut, and then I could just complete this Rhexis. Yes. So this is the Argentinian flag sign which I faced. So what are the options, phaco or SICS? I usually take whether it's a soft cataract or hard. If it's a hard cataract, for sure I do SICS. But if it's a soft cataract, I try to do semicircular Rhexis on both the sides and then try to aspirate, because this nucleus is so soft that after gentle hydro, you can just aspirate. You don't require much of the power. Now, how to do a semicircular Rhexis on this side? So being a retina surgeon, I take liberty of using vertical forceps. I created a nick on this side and I did semicircular half Rhexis on this side as well. And since this was a soft cataract, I was able to remove this cataract even after with the Argentinian flag sign, and I continued with phaco. But mind it, if it's a grade 3-4 nucleus, or if it's a hard brown nucleus, you have to convert to SICS, and see this is the same case, and I am inserting the IOL in that Argentinian flag sign case.
1 minute left.
So now this is one more intumescent cataract where the Rhexis is extended posteriorly. Now here I say you have to handle that flap briskly. You have to inject ample visco. Then you have to pull that flap towards the center. This is not for beginners, mind it. And then you have to pull that flap towards the center. You should be brisk. It is said don't give time Rhexis to extend. And see, I am trying to pull this briskly. And after coming here, I will be injecting visco again. And then I will be pulling this flap briskly again towards the center. And you can see how nicely that complete turn would be taken care of, and just a bit will be remaining. And now watch here what I'm doing, catching the flap, and I will be little brisk and pulling it towards the center. See, yes. And this Rhexis was done. You have to pull it briskly towards the center. And now the Rhexis part was done. However, it was a little large enough, but nicely done in a case of intumescent cataract. Now to complete this video, I am showing 2 more cases where, in some cases where you find that your Rhexis is small, you inject visco and you can enlarge at the end of the case. So here is one more case where I tried doing Rhexis enlargement under saline. And you can see my aspiration cannula is inside, irrigation cannula is inside, and I made a small nick. And I would be just making this Rhexis big under saline, and you can see that flap fluttering. And you can watch here the flap flutter under saline, and then the Rhexis was completed.